what is basically extrapyramidal system, its brief anatomy, what are the differences between pyramidal versus extrapyramidal system in neuroaxis, what are different types of extrapyramidal disorders that we know about, and in the last we will discuss the most hallmark and well-known disease of the extrapyramidal system and the focus of much research, Parkinson's disease. In this lecture, we cannot discuss all extrapyramidal disorders in detail, but we will briefly discuss which type of extrapyramidal disorders can be because of this dysfunctional state in the extrapyramidal system. So to start with, what is extrapyramidal system? Originally, that you know that this system is called extrapyramidal to distinguish from the traits of the motor cortex that reach their targets by traveling through the pyramids of the medulla. We know the pyramids of the medulla where corticospinal tracts merge and decussate. This is pyramid is formed by these directly controlling motor fibers to spinal neurons called corticospinal tracts. To distinguish from these tracts, this extrapyramidal system or extrapyramidal neuro axis is used specifically distinguished from this the descending corticospinal tracts and their pyramidal connections. The extrapyramidal system is also often described as the motor modulation system. While we know that corticospinal tract is directly executor of the motor function, but this extrapyramidal system is not direct, but it indirectly modulates the motor execution of the corticospinal system. The term extrapyramidal is to distinguish between the effects of basal ganglia disease and those of damage to the pyramidal system. We know that when there is damage to pyramidal system, for example, in case of a stroke, there is spasticity or spastic weakness on contralateral side. But in extrapyramidal disorders, there is no such motor weakness, but there is some problem in the tone of the muscle, maybe leading to rigidity. Maybe there is a problem in maintaining movements with extra or involuntary movements, for example, resulting in tremor, chorea with this dysfunction in extrapyramidal system. So there is basically difference of presentation of extrapyramidal from pyramidal system in disorders. This is briefly about anatomy of the extrapyramidal system. As you can see here, the nucleus structures of extrapyramidal system of the basal ganglia. They are basically basal ganglia are the nucleus structures of extrapyramidal system. And extrapyramidal system also has descending tracts like pyramidal system. So the nucleus structures are basal ganglia of the extrapyramidal systems that are mainly for example, caudate nucleus, as you can see here, and putamen, globus pallidus with internal and external segments, red nucleus, substantia nigra, subthalamic nucleus, and also connections with the thalamus. They form basically the nucleus structures of the extrapyramidal system. So extrapyramidal motor system includes corpus striatum, subthalamic nucleus, substantia nigra, red nucleus, brainstem reticular formation, descending spinal tracts other than corticospinal tracts. There are also extrapyramidal system. As you can see here, these are the corticospinal tracts originating from the pyramidal system or cortex, and in the medulla they decussate to opposite side to innervate the neuromuscular junctions through anterior horn cells. But these nucleus structures of this and the basal ganglia, they modulate these corticospinal tracts, as well as they directly descend usually ipsilaterally to anterior horn cells and modulate motor activity indirectly. So what is basal ganglia? Basically, basal ganglia, as you can more clearly hear the nuclei of the basal ganglia with caudate nucleus adjusting this lateral ventricle. Lenticular nuclei basically both putamen and caudate or putamen and globus pallidus, they are called lenticular nuclei. Substantia nigra, which is the area where degeneration occurs in case of Parkinson disease here, lying in the midbrain with subthalamic nucleus. And as you say here, this is globus pallidus. So these are the nuclear structures of the basal ganglia. This is projection of these nuclear structures in the brain, as you can see, is visualized from a side of the brain. So here, how this nuclear structure is formed between different nuclei. This is basically caudate nucleus, and here this is in a red area. You can see this is putamen, but this dashed area, and it is more medial. It is globus pallidus. And again, the blue one is thalamus here. This is the amygdala. These are basically not direct part of the basal ganglia, but they have close relation with this basal ganglia structures. Along with this, the substantia nigra in the midbrain, they also form very substantia nigra and subthalamic nuclei. They form very close relationship between and connections of basal ganglia. So extrapyramidal structures include corpus striatum formed by caudate nucleus in putamen, subthalamic nucleus, globus pallidus again has two segments as we saw in the structure, external and internal segment, substantia nigra which is pars reticulata and pars compacta. What are different extrapyramidal tracts? These are the extrapyramidal nuclei. Now extrapyramidal tracts, very important extrapyramidal tracts, descending tracts in the neuroaxis. These include rubrospinal tract from red nuclei, reticulospinal tracts that originate from pontine and medullary reticular formation, vestibulospinal tract and tactospinal tracts. These are major extrapyramidal tracts that indirectly control the motor movements of anterior horn soils. Here you can see on the right side the descending motor pathways or tracts, and these are the ascending sensory pathways. So in motor pathways you will see that the pyramidal tracts, the most important pyramidal tracts are the corticospinal tract, that are lateral corticospinal tracts over here, and these anterior corticospinal tracts. Other than those, these two tracts, other most important tracts are basically extrapyramidal tracts. As you can see here, rubrospinal tract, reticulospinal tract, this is olivospinal tract and vestibulospinal tract. So pyramidal tracts, which are corticospinal and corticobulbar, they directly innervate motor neurons of the spinal cord or brain stem. For example, in anterior horn cells are certain cranial nuclei in the brain stem. Whereas the extrapyramidal system, this centers on the modulation and regulation, that is indirect control of anterior horn cells. So clinically the term extrapyramidal was thus adopted to distinguish between the clinical effects produced by a damage involving the basal ganglia and those of damage to the classic pyramidal pathway. Despite this distinction, however, there are important anatomical and functional relationships between the two systems. Briefly, what are the functions of the extrapyramidal system? It serves an essential function in maintaining posture and regulating involuntary motor functions. In particular, the extrapyramidal system provides postural tone adjustments. For example, damage to extrapyramidal system will lead to rigidity in performing movements that make voluntary movements more natural and correct, control of automatic modification of tone and movements, control of the reflexes that accompany the responses to affective and attentive situations. For example, patients with Parkinson disease have masked facies. They do not give the affective look when they are affected with Parkinson disease because of the damage to the basal ganglia. Control of the movements, originally voluntary, then become automatic through exercise and learning. For example, writing, with repeated writing you will become more accurate and writing will be more clear. This is because of the modulation by the extrapyramidal control. Inhibition of involuntary movements. Involuntary movements, if they are not inhibited, they will cause hyperkinetic movement. For example, tremor, chorea. These are also resulting because of the less inhibition of involuntary movements, which is the function of the extrapyramidal system. So the clinical relevance of the damage or the dysfunction to the extrapyramidal system can lead to different forms of movement and cognitive disorders. Injury to the pyramidal system induces paralysis. Pyramidal system. What is pyramidal system? This corticospinal system. For example, when it is affected in stroke, it will cause what? Spastic paralysis on the contralateral side. Whereas extrapyramidal tract disorders result in involuntary movements. For example, tremor, chorea, athetosis. They may result in muscle rigidity and immobility. For example, in Parkinson's disease, Wilson's disease, but without paralysis. Paralysis is not a feature of extrapyramidal disorders, it is a feature of pyramidal disorders. In some cases, both pyramidal and extrapyramidal systems are affected, such as spastic athetoid cerebral palsy. So, extrapyramidal disorders are what? Basically, they are the disorders resulting from damage to the extrapyramidal system that we discussed briefly in anatomy. So these extrapyramidal disorders, these are the neurological syndromes or disorders in which there is either an excess of movement or paucity or slowness of voluntary and automatic movements. So either there is an excess of movement or slowness or paucity of voluntary and automatic movements because of the damage to the extrapyramidal system, and it is unrelated to weakness or spasticity, for example, which that occurs in stroke. There are two types: hypokinetic, akinetic-rigid syndrome, hyperkinetic. Hypokinetic are disorders that result in paucity, slowness of movement, while hyperkinetic are disorders that are characterized by excessive involuntary movements. The most important hypokinetic or akinetic-rigid syndrome disorder that is well known is Parkinson's disease. So Parkinson's disease and other causes of Parkinsonism are hypokinetic disorders that include Parkinson's disease plus disorders like progressive supranuclear palsy, PSP, MSA, multiple system atrophy, cortico-basal ganglionic degeneration, Wilson's disease, hydrocephalus, Lewy body disease. These are some of the examples of hypokinetic or akinetic-rigid syndrome. These disorders are characterized by akinesia or bradykinesia, rigidity, tremor at rest, postural instability, inflection posture, so frequent fall, gait freezing, difficulty in walking. While hyperkinetic disorders, what are the most common hyperkinetic disorders? Hyperkinetic extrapyramidal disorders: chorea, dystonia, myoclonus, or restless leg syndrome, tremor, and tic disorders. These are the common hyperkinetic disorders resulting from the damage or dysfunction of the extrapyramidal system. These are less common disorders. These are also resulting from extrapyramidal structural damage that include akathenic movements, valismus, athetosis, myokemia, and paroxysmal dyskinesias. So the basic pathophysiology of these hyperkinetic or hypokinetic disorders is again in structures involving the basal ganglia. These basal ganglia structures that we discussed already, they do not connect directly to spinal neurons. They exert their influence indirectly via corticospinal, tactospinal, and reticulospinal tracts that we discussed. Lack of directly sensory input and motor output suggests that they act as modulators rather than executors of movement. Executor of movement is basically cortex. They are the modulators of movement. So their projection from cortex come to striatum, basal ganglia, and through pallidum they come to thalamus, and then again to cortex. And through cortex they indirectly modulate motor movements. In this structure, again, a briefly concept about the extrapyramidal disorders. You can see this balance when loss results in extrapyramidal disorders. So, the cerebral cortex directly control or executes the movements through spinal neurons and through spinal neurons to muscles. While these basal ganglia structures and cerebellum, they indirectly modulate or they control the smoothness of movements through their projections to cerebral cortex and anterior horn cells. We will discuss briefly about the Parkinson's disease, the very important topic of extrapyramidal disorders. So, what is Parkinsonism? Basically, it is a cardinal tetrad that include tremor, rigidity, bradykinesia, akinesia, and postural instability. It is called Parkinsonism. And the most common cause of Parkinsonism is Parkinson's disease. We discussed that there are other causes of Parkinsonism as well. As I discussed in this slide, PD plus disorders like PSP, MSA, corticobasal ganglionic degeneration, Wilson disease can cause Parkinsonism, hydrocephalus, NPH, normal pressure hydrocephalus can cause Parkinsonism, Lewy body disease can cause Parkinsonism. So Parkinsonism is basically syndrome, it is not a specific disease, while Parkinson disease is a specific disease, which is most common cause of Parkinsonism. And this is idiopathic basically disease. And it is second most common cause most common cause of neurodegenerative disorders after Alzheimer's disease and affects around 2% of the population over 60 years. Majority of Parkinson disease cases are sporadic, but inherited forms of Parkinson disease also occur mostly at a younger age. Main pathologic process in Parkinson disease is the degeneration of the dopaminergic neurons in the substantia nigra that we discussed. And mechanism responsible for neuronal degeneration is probably multifactorial and based on a combination of genetic and environmental factors. Basically, there is loss of neurons in the substantia nigra and 70 to 80% loss of neurons, and there is presence of Lewy bodies in remaining intact neurons in Parkinson disease if you do biopsy. So, nigrostriatal dopamine loss and severity of motor symptoms, they are interrelated. The more the nigrostriatal dopamine loss, more severity of motor symptoms. And it will result in reduced activation of dopamine and increased activity of striatal cholinergic activity. This is what that occurs in Parkinson's disease. This pigmented area in the midbrain, which contains dopamine containing neurons in substantia nigra, this is lost in case of Parkinson's disease. Here you can see this loss of this pigmented area of substantia nigra, which contains dopamine. This is what that is usually observed in patients with idiopathic Parkinson disease. And this loss of dopamine, because basically these substantia nigra, they give projections called nigrostriatal pathways to basal ganglia structures. This potamen encoded. So this projection containing dopamine becomes less active when there is dopamine deficiency in case of Parkinson disease because of deficiency or degeneration of the dopamine contained neurons in the substantia nigra. So overall, the movements will become slow and there will be rigidity and postural instability. So these are the symptoms and signs associated with Parkinson disease because of the loss of the dopamine in dopamine containing substantia nigra. Parkinsonian patient will look like this, especially the well-established advanced Parkinsonian patient with mouse-like facies with no expression, as we discussed. There is loss of affective movements as well in Parkinson disease and other disorders associated with extrapyramidal disorders. There will be tremor, asymmetric resting tremor. Initially, it may become more symmetric or bilateral with the time, but initially there is asymmetric or unilateral tremor because of the contralateral damage in the basal ganglia structures. Patients have postural stability. If you check their stability, postural stability, it will be positive and they have tendency to fall. Patients will present with shuffling steps and freezing, basically the stoppage of gait for a brief moment, and on examination you will see rigidity. When you check for tone, arm swing will be decreased, there will be overall slowed movement. What are the motor symptoms of Parkinson's disease and non-motor symptoms? Basically, they present with motor symptoms, but equally there are more important non-motor symptoms. The motor systems, more important symptoms of Parkinson's disease that include in all Parkinsonian patients, they are basically the resting tremor, rigidity, bradykinesia, postural instability, the fascinating gait, micrographia, marked facies, retropulsion, and hypophonic speech. Non-motor symptoms are equally important as well because of the basal ganglia not only modulates the motor movements, but it has important connections with, for example, amygdala and other medial temporal lobe structures. So they may present with other non-motor symptoms. Sometimes these non-motor symptoms, especially for example impaired olfaction, constipation, sleep disorders, they may predate these motor symptoms. So these are equally important. autonomic dysfunction, impaired olfaction, dementia. Ultimately, majority of patients, impulse control disorders and psychosis may be present along with these marked motor symptoms of Parkinson's disease. Diagnosis is basically clinical, and there's no laboratory imaging test that is confirmatory. But here you can see fluorodopa uptake tests, in which you can see fluorodopa is basically dye. In healthy control, you will see the normal uptake of dye in the basal ganglia structures. You see the potapital uptake of normal uptake of this dye, fluorodopa. But in case of early Parkinson's disease, you see there is decreased uptake of dye on one side, and that's why the tremor and other rigidity and other symptoms will be contralateral to this side initially. Later on, both sides you will see the decreased uptake of fluorodopa uptake and symmetric loss of basal ganglia structures because of the damage to the nigrostriatal pathway in Parkinson's disease. So PD is a progressive neurodegenerative disorder. Because dopamine deficiency causes the main motor symptoms, replacement of dopamine with dopaminergic medication is a major medical therapy. Non-dopaminergic medications like anticholinergics, antiglutaminergics, and muscle relaxants are also used to treat motor symptoms. And there are also non-dopaminergic medications that are used for non-motor symptoms, for example, dementia, sleep disorders, anxiety. So, what are different dopaminergic drugs? Dopamine precursor, levodopa, which is commonly used with the name of Finemet, and this is used with carbidopa, which is peripheral inhibitor of this precursor to dopamine. So basically, this is a precursor of dopamine, and it converted to dopamine in brain when it crosses the blood-brain barrier. Dopamine agonist drugs, for example, bromocriptine, pramipexole, ropinirole, apomorphine, and we have ropinirole in Pakistan available. COMT inhibitors, which is catechol methyl transferase inhibitors, and monoamine oxidase B inhibitors. These are also drugs which inhibit the metabolism and they break down the dopamine. Basically, when they are inhibited, there will be more dopamine level in the brain. COMT inhibitors include entacapone, tolcapone. Sometimes in combination levodopa they are used. And salicyline and rasagiline, these are the monoamine oxidase B inhibitors. So these are all dopaminergic drugs. There are non-dopaminergic medications as well, because cholinergic activities increase in case of Parkinson's disease, so anticholinergics sometimes help, and many times they are important drugs, especially control of resting tremor. Triaxphenidil, diphenhydramine, amitriptyline, they are used in case of the more predominant motor symptoms of tremor. Anti-glutaminergic drugs, for example, amantadine, because glutaminergic, basically glutamine is an excitatory neurotransmitter and it causes excitotoxicity. So this excitotoxicity is decreased by amantadine. GABAergic drugs with lorazepam, clonazepam, they are used for sleep induction and decrease anxiety in patients with Parkinson's disease. Atypical neuroleptics, when there is psychosis and other issues related to Parkinson's disease or otherwise. So the only atypical neuroleptics can be used. Atypical neuroleptics, the most important one that we use in Parkinson's disease or we can use are quetiapine and clozapine. Because the more typical neuroleptics like haloperidol, they may worsen the Parkinsonian symptoms through their more anti-dopaminergic activity. Surgical treatment has become more important in this disease, especially Parkinson's disease, this DBS procedure. Previously, there were unilateral stereotactic lesioning of the pallidum, which is called pallidotomy or thalamus-thalamotomy. They were being used to relieve symptoms of Parkinson's disease in 1950s. But the development of this DBS procedure, deep brain stimulation, this has revolutionized the surgical treatment of advanced Parkinson's disease. And in this DBS procedure, electrodes are placed into the specific sites in basal ganglia, and they are attached with a pulse generator, which generates high-frequency electrical stimulation. As you can see here, this electrode placed inside basal ganglia structures. In Parkinson's disease, usually the subthalamus nuclei are chosen. They are basically the targets of DBS procedures, and this wire comes and is attached with this pulse generator or stimulator that is placed subcutaneously under the clavicle. This generates pulses which are transmitted to the basal ganglia structures, and they basically mimic the normal stimulation of the basal ganglia because there is deficiency of dopamine. So through this stimulation, they somehow manage normal stimulatory circuits in the brain, which produce especially all symptoms of motor symptoms of Parkinson disease, including this tremor, rigidity, and bradykinesia. Thank you very much. This was about briefly